I just want to thank you, Gordon, for inviting me to give this topic. Now, I'm sure some of you are probably saying, well, an orthopod and genetics is not an obvious match made in heaven. But I do have some kind of vicarious link to it, because Francis Crick, who many of you know, was with Watson, was given the Nobel Prize for discovering the double helix. He was actually born in my little village and attended the same school as me, obviously a few years ahead. But I'm now a governor back at that school, and you go in there and as you go through the entrance, there's a great big thing about Crick and his work. So I've always had a bit of an interest in genetics, and I've always thought it's going to be important as we go through our careers in dealing with some of the musculoskeletal problems that we find. And I was very taken by this paper in 2006, talking about the effect on collagen structure of your genetic variations and what it may do to your Achilles tendon. And I was in Cape Town for a different reason, and I just emailed these guys. Martin Schwellnus, some of you may know, is a fantastic sports physician, and Malcolm Collins is a cell biologist and geneticist. And I said, you know, I'm in Cape Town for the weekend. Can I meet with you? And they were incredibly hospitable, took me out to lunch, and for the last 17 years, we've had a wonderful collaboration. Now, the same year, I was also kind of interested in this paper that had come out from the vets, and I put this in last night. And this was the work that was coming out of Japan and from London, looking at what was happening to young horses. And some of you may never have heard of COMP, but it's a glycoprotein which actually binds your type 1 collagen together and gives it strength. And this group described what happened to young horses if they didn't do any training at all. Their tendons would be weak. If they overtrained, then their tendons would be damaged. And so there was just the amount of incremental training for young horses to give them the best strength. And what also interested me was that in man, that if you have mutations in the gene, it will cause achondroplasia. I was even more interested because Roger Smith lives less than a mile away from me in the East Midlands, and his wife is my doctor. So we spent a lot of time talking about this. And those combined things led to this interest. Now, we all learned at medical school about the structure of our tendons. The tenoblasts become the tenocytes in the extracellular matrix. And wherever you look within your tendon, whether it be the components of your extracellular matrix, the various components of your cells, and that critical interaction between them, we will all have genetic variations. So over the last 17 years, it's been a wonderful kind of relaxation and deviation for me from dealing with bunions. So we published quite a bit on this over the years, and I'm not going to go through every paper, but just for the vets, you'll see that Roger Smith also appeared on some of our publications. Now, many of you will be aware of this view about how injuries are caused. Muvisa, if that's how you pronounce it, published this 30 years ago. And it was a combination of intrinsic factors, extrinsic risk factors, and the inciting episode. I know it's been modified, but I still think it's a good way of viewing things. And if you look at our intrinsic risk factors, anatomical variations, the slope we'll have on our tibial plateaus, we've been talking about, it's often a combination of genetic and environmental factors, although obviously sex determination is supposedly genetic. Now, that will give you a predisposition to having your Achilles or any other tendon or ligament you think about being injured. If you then add in the extrinsic risk factors, which may be anything from your environment, nutrition, drugs, training problems, you then become susceptible. And that tendon, that anterior cruciate ligament that you showed, Antonio, will begin to show evidence of damage unbeknown to the patient or the animal. And then you have that single inciting episode, if you're talking about a cruciate ligament rupture or an Achilles tendon rupture, when the whole thing just falls apart. The other way I try to think about what genetics may be doing to our soft tissues is I adopted this, which is the jar model, which was actually first brought about by psychiatrists to have a look at people's predisposition to psychotic episodes. So hopefully most of us in this room have a low predisposition. This is our jar, and hopefully we're loaded right at the bottom with just one or two genetic risk factors. And that means that we can abuse our bodies and as much as we want with environmental risk factors, and we'll never overflow our jars. But unfortunately, a few of us will have a high predisposition. We'll be born with our jars packed full of genetic risk factors. And it doesn't therefore take much in terms of environmental risk factors, too much training, poor shoes, or whatever you're going to do to make our Achilles tendons get inflamed or whatever else you might think of. And one of the tasks really of when we get our patients coming in with great big swollen Achilles or whatever is to try and keep a lid on things. So therefore we want to try and reduce those environmental risk factors and try and put in some positive things, prophylactic stretching, whatever else we're going to do to try and keep our Achilles tendons and everything else under control. Now, the effect that your genetics will have on your tendons will be both in the quantity, and this is really building on what Rob was saying, but also the quality of the tendon component parts. I don't know how many of you remember, but in the late 90s and around 2000, people like Nicola Mafuli, or some Hungarian papers, suggested there was a link between Achilles tendon ruptures and what ABO blood group you were. And so there was some varying evidence for this, which wasn't clear. But what was clear was that we really should start looking at the long arm of chromosome 9, because that's where your ABO gene is. And there it is, sitting there at this gene loci. But it wasn't anything to do with your ABO blood status. What it was that various genes which code for the quality of your tendons sit right next to it. Tensin C, which is a glycoprotein, and Col5A1, which we'll come back to, is very close. So you just inherit these things along with your ABO blood group. So it was just a coincidence. So is it inevitable that if we're born with a certain genotype, that we are going to rupture our Achilles tendons, have a swollen? Well, the answer is you're only going to have connective tissue pathology for certain if you've got these classical monogenic disorders like Rob just showed, kind of Ehlers-Danlos and things like that. But for most of us, it's a combination of genetics and environmental factors. And therefore, what we try to do with a lot of the genetic research is try and find out which are important and to talk about relative risk, to try and give some weighting to what are the genetic factors that are most important. Now, I'm glad, Rob, I wasn't the first person to talk about MMPs today. But for instance, if you've got a particular genotype for MMP3, then your risk of getting Achilles tendinopathy increases to 2.5 times. And for those of you who don't think very much about MMP3, you may well have seen patients coming into your clinics who've suddenly got a great big swollen Achilles tendon, and they've had ciprofloxacin or some other antibiotic given a few weeks beforehand. And it's the fluoroquinolone antibiotics act on MMP3. So I'll just say a little bit. So Rob's already talked about type 1 collagen. We know that's the main structural collagen for our tendons and our ligaments. But all the other lesser collagens are critically important. And if we could just concentrate on type 5 collagen, because the quality of your type 5 collagen and the number will regulate your Achilles tendon strength and its diameter. So hopefully you've got normal type 5 collagen, and this arrangement that Rob showed in his diagrams, that's what our collagen, that's what our tendons will look like. But if you're unlucky enough to have an excessive amount of type 5 collagen, it completely changes the microstructure of your tendons, and it will increase your risk of damage. So just staying on the type 5 collagen, if you're unlucky enough, well, you won't live it. If you've got 2 copies of a mutated Col5, you'll actually be aborted in utero. If you've got 1 copy of a mutated Col5A1 gene, then you'll get one of the 13 different types of Ehlers-Danlos. There is a view that benign joint hypermobility syndrome has also got the COL5A1 also has a role with that. You may be unfortunate enough to have one of the bad alleles that will increase your risk of an Achilles tendon injury, but equally you may have ones which decrease your injury risk and make you feel like Superman. 15 years ago, nobody talked about epigenetics, and I don't know how many of you are familiar with it, but epigenetics is the way that the cell deals with how much of our DNA is exposed. We've got the same DNA in every cell, but obviously one's going to be an hepatocyte making liver organ, and one's going to be a muscle. So only certain amounts of DNA is exposed in certain areas. And what we've come to understand is that other factors will affect how much and which of your DNA is exposed, and things like age, nutrition, training load. For instance, many have done pediatric orthopedics and you've seen children with neural tube defects, and that's because some of their DNA has been excessively methylated, and that's why we give pregnant mums folate. Now the bad news is that we become older due to epigenetics. Our tenocytes become flatter, they communicate less with each other, and they're less numerous. And also we get increasing methylation of our major structural type 1 collagen. So this is why our tendons are gradually going to degenerate. So just to wind it up, what considerations might we apply to genomic research managing tendinopathy? Certainly the cohorts that I put together in South Africa and Australia, we've concentrated on the Caucasian population for ease of analysis. We need to know if it translates to other ethnic groups. It's a fantastic area of research to be involved with because it's never ending. It's like a 2,000-piece jigsaw, and you're just trying to put pieces in and find out how important they are. As I said earlier, what we're trying to do, we've got this basket of genes, and what we're trying to do is to define which are important, and trying to then add up the importance if you to genetically profile somebody and to find out, to add up their scoring systems and their risk factors. I believe that we do have tendinopathic personalities. We need to establish which epigenetic factors are important, in terms of nutrition and other things, for making our patients more susceptible, and how we may alter that. And I don't know what it's like for you, but 20 years ago, I was doing a lot more non-insertional Achilles tendon surgery than I am now, because we found lots of other means of treating them. But I have a feeling that there are some patients who just will not respond to anything you do, which comes around to the most important slide in a minute. What might we do in the future? Well, DNA editing. We may have that ability to be able to identify that poor gene for any disorder or disease that we may think of, and be able to go in and snip it out and put good genetic material in instead. But to finish, do we have to accept that some people will not respond to any treatment because of their genotypes? Or do we have to say, I'm really sorry? So really, the last thing to think about is that when you've got that patient in your clinic and they are absolutely fed up, and that you've tried everything and you really don't know what to do with them, if you just simply say to them, you've got the TT genotype for the COL5A1 gene and there's nothing I can do, it's all in your genes. Thank you very much.